I'm Delanne Elliott Midland. I'm the president and CEO of the End Brain Cancer Initiative. I want to welcome all of you today to the new developments in PCNSL treatment webinar. I am so delighted to bring to you Dr. Nayak. She is the neuro-oncologist and director of the Center for CNS Lymphoma, Harvard Medical School. And she's going to be talking to us today about the PCNSL study results and new clinical trials. And she is in Boston. She is an associate professor of neurology at Harvard. She received her medical degree at Grant Medical College in Mumbai, India. She completed her residency at New York Presbyterian Hospital, Cornell, and fellowship at Memorial Sloan Kettering Cancer Center in New York. Her research includes development of novel therapies through preclinical and clinical studies for management of primary brain tumors, including glioblastoma and primary central nervous system lymphoma, with particular focus on molecular targeted agents and immunotherapeutics, including CAR T-cell therapy. She leads the International Neurologic Assessment in Neuro-Oncology, NANO, effort for evaluation of neurologic function in patients and brain tumors. Dr. Nayak, thank you so much for being here. I wanted to, before we get to see your presentation and hear your presentation, I wanted to read one of your patients said this. My wife and I are very grateful for the care that Dr. Nayak has provided me. She had clearly reviewed my files and spoken to colleagues both at Dana-Farber and elsewhere about my case. Her counsel is clear, and she answers my questions and my wife's questions clearly and thoughtfully. We are thankful for both her expertise and her patience and her generosity of spirit. Welcome, Dr. Nayak.
Thanks, Delanne, and thank you for End Brain Cancer Initiative to feature primary CNS lymphoma. I particularly in my talks talking about this and what patients and their lives and what this disease can do, not just to them, but the caregivers means, and how it's so inspirational to me and my colleagues. But I think I wanted to start with that, especially because you shared the story of Neil and Dawn, and it just seemed like the right thing to do at the right time. It was just reminded me of why we all do it. So thank you for sharing that. That was really special. Let me share my slides. I'd like to thank you, Delanne, and Brain Cancer Initiative, and all the collaborators that got together to make this happen. I will speak about clinical trials, some of them that I've been involved in. To start with, though, I figured, it's best to talk about a little bit of a background on primary CNS lymphoma since I'm the first speaker. As many of you know, primary CNS lymphoma is a rare tumor. It's a variant of extranodal non-Hodgkin's lymphoma that is restricted to the nervous system. And here, by the nervous system, we mean the brain, the spinal cord, the leptomeninges or cerebrospinal space, and eyes, in the absence, importantly, of systemic disease. As you just saw in the video at the end, that this is a rare cancer with an incidence rate of about 0.4 per 100,000 person year. But its incidence is slightly higher in people over 70 years of age. It accounts for 6% of all malignant primary CNS tumors, so still rare even when you think of brain tumors that are rare as a whole. And then it accounts for 4 to 6% of non-Hodgkin's lymphomas. The median age at diagnosis is 65, so older people account for more than half the cases. And we've noticed through population studies that the incidence rates are increasing in the age group of greater than 65 since the 2000s, and it's still unclear why that is happening. With regard to pathology, 90% of these are diffuse large B-cell lymphoma, and then the less than 10% are other types of lymphomas, including T-cell lymphomas. And for the focus of this talk and for the greater part of this entire webinar, we will focus on diffuse large B-cell PCNSL. What is important to know is that when we look at the tumor tissue in the very traditional way of histopathology, looking under the microscope, it looks identical to systemic large B-cell lymphoma. And yet we know that it doesn't respond as well as other chemotherapies to systemic lymphoma do. And so we determined over time that upon gene expression profiling, it fits into what is called as the ABC, or the activated B-cell subtype of diffuse large B-cell lymphomas. But then further, we have learned that upon comprehensive genomic analysis that started being done about 15 years ago now, that this is actually a very distinct disease with unique targets. It now fits into a specific subtype of diffuse large B-cell lymphomas, also that fits into what is called cluster 5 or MCD, based on the classifications from genomics in diffuse large B-cell lymphoma. What about symptoms? Well, it's important to note that while symptoms do develop, and some of them may be specific or non-specific, most of the neurologic symptoms are actually not specific for primary CNS lymphoma or even brain tumors in general. And I thought that was very poignant, what Dawn had said in the video, that she never really thought that the symptoms would be suggestive of a brain tumor. And so it's important to note that many of these symptoms can be easily mistaken, not just for other brain tumors, but for a number of neurologic conditions. But what we do see time and time again is that in the majority of patients, about 60% or so, do have memory problems or cognitive impairment, personality changes. And then close to 60% also have trouble with walking and gait disorders. About 40% of people have weakness of any one side of the body or sensory changes. And about a fourth of people have headaches or other signs of what we call raised intracranial pressure, such as changes with their vision and some confusion and feeling of fullness. And then something to point out, especially from a brain tumor perspective, when you think of brain tumors, you think of seizures, because many of the other types of brain tumors, seizures are a very common presenting sign. And then in primary CNS lymphoma, though, seizures have been seen in about 12 to 14%. So it's not that they're not seen at all entirely, they're uncommon. And then here I talk about performance status, and I'll talk a bit more as we go through clinical trials. What does this mean? This is how people are performing overall. Are they able to, take care of themselves and perform their day-to-day activities? And this is an important number that we look at as physicians when we're thinking of offering treatments, but also when we're thinking of trial eligibility. And so that's the only reason I mentioned performance status over here. Brain tumor lesions are most common. However, concurrent eye involvement can be seen in about 20 to 30% of patients. So we always like to see an eye exam at some point during the disease course to rule that out. Leptomeningeal diseases or CSF involvement is seen in as low as 7% of people to as high as 40%, depending on the case series that we're looking at. But isolated eye disease and isolated spinal cord disease is quite rare. The International Primary CNS Lymphoma Collaborative Group, or IPCG, recommends baseline evaluation when people are diagnosed. And the main part of this is really what is called extent of disease evaluation. So what does that mean? Well, first of all, we want to see the extent of the lymphoma in the nervous system, because this is not localized only in the brain if this is where it was found. This is thought to be of a whole CNS disease at a microscopic level. And so it's important as we assess a response to treatments how do we see it as a whole? Where all is it hiding, this cancer, if you may? And so that's why we recommend an MRI of the brain and spinal fluid testing, and a slit lamp exam to evaluate the eyes. And then importantly, because body lymphoma is actually more common, we do recommend systemic staging in the form of a PET scan of the body or a CT scan of the body. And particularly if a CT scan is done, we recommend to obtain a testicular ultrasound, especially in older men, because primary testicular lymphoma has a high predilection for the nervous system or the brain. It's important to note that identification of concurrent systemic disease will change not only the treatment, but also the outcomes of the tumor. What are the prognostic factors? Well, we have two prognostic scoring systems. One is the MSKCC scoring system that was developed in the US, and the other one is the ILSG scoring system, which was developed in Europe. What is important to note is that age and performance status, that is how fit you are physically, are the only two factors that have been found to be associated with prognosis. So the younger people are and the more physically fit they are at the time of diagnosis is thought to be associated with better prognosis. And when you think of cancer, we've made several advances in different types of cancers where we've identified predictive markers or prognostic markers that are based on genomics. But in this disease, we still haven't identified that. However, potential biomarkers may include circulating tumor DNA, and there is a talk following this talk that will cover that, but I'm just giving a shout out to Dr. Lilly as he prepares to give that talk next. So where did we start with treating this disease, and where are we now? Well, up to the 1980s, whole brain radiation was the only treatment that was used for primary CNS lymphoma treatment. Now, while we saw that people had very good responses, the long-term control was very short. People recurred within a year. The addition of high-dose methotrexate changed outcomes in the 1990s. However, increasingly, it was noticed that there's a high risk of neurotoxicity where people started having long-term problems related to their memory, balance, cognition, and just overall brain health by the combination of the two. And so the 2000s saw the introduction of chemotherapy alone, and this was further high-dose chemotherapy and autologous stem cell rescue. And while this approach seems to be really very good and obtaining really good results, it turns out that this can be offered only to a select patient population. So where are we in 2026? We're in the age of targeted therapy, immunotherapy, and cellular therapy. I like to show this slide as to, just seeing what the NCCN, the national guidelines, or cancer center guidelines recommend for management and where we are. And so clearly in newly diagnosed setting, there's clear guidelines that high-dose methotrexate-based chemotherapy is recommended. And then consolidation is recommended if possible. And then there are several options that are pretty much, physician's choice of pick in terms of salvage for relapse and refractory disease. However, it's very important to note is that the NCCN and we as physicians always recommend clinical trials as the best management for any patient with any cancer. And this is particularly important in this rare disease so that we can make progress and have more cure rates. What are the challenges that we've had, which leads me to what I'll talk about with the upfront, is that we've seen that auto transplant works really well. And so does whole brain radiation, but it's ideal only for a select population. This is the young population with minimal and no comorbidities. We already talked about the fact that the majority of people are 65 and older, And so that puts us in a little bit of a pickle over there with regard to what can be truly offered everywhere. Another part is that not everyone actually responds to high-dose methotrexate-based chemotherapy. And so transplant is really an option for what we call chemosensitive disease. And so 15 to 33% of patients are actually refractory to the initial high-dose methotrexate-based chemotherapy. And then additionally, recurrence risk is high. So we've completed all therapy and people are in what we call CR, had a complete response. And yet we see that these tumors find their way back into the brain within the first couple of years in about 50% of people. So what happens at that stage, which is salvage? Well, we have no standard of care options. And so there's an unmet need to optimize treatments. And the only can actually add to and better our treatments are by doing clinical trials so that we can show and prove that newer therapies work. I mentioned a bit earlier when I showed that slide on the pathology of how we, over time, we and others have identified from a genomic standpoint several targets. And during this talk and over the course of the next few talks as well, we'll focus briefly on a few specific targets that we think are very important, namely the BTK, IRAK4, and then, of course, CAR T-cell therapy. I'll start with the BTK pathway. And to speak briefly about that, we know that all primary CNS lymphoma are driven by what is called the B-cell receptor signaling and the toll-like receptor signaling pathway as a result of these MYD88 mutations. And so one target here to sort of prevent and block this growth of tumor cells is by blocking BTK. And this has been studied in primary CNS lymphoma now with the first generation drug, ibrutinib, and then the next generation drugs, tirabrutinib and zanubrutinib. So I'll start with the second generation drug and some of these new results that came out last year. And I'll discuss the results of this study, which is tirabrutinib, which is a second generation oral BTK inhibitor in relapsed refractory primary CNS lymphoma. And this was a study that was conducted in the United States upon the heels of a trial that was conducted in Japan that led to its approval for relapsed refractory disease in Japan, Taiwan, and South Korea. The trial design was pretty straightforward. It included all adults over 18 years of age with a ECOG performance status of up to 2. And then patients needed to have had measurable brain lesions so that we could actually measure the response and see shrinkage of the tumor when they received the therapy. And they had to have received at least one prior line of treatment for their primary CNS lymphoma, which included high-dose methotrexate. All patients received tirabrutinib at 480 milligrams oral daily in a fasted state. And what we wanted to look at was basically how many people would have a complete response and how many people would have a lasting response. And these are the results where we saw that the overall response rate was 67% in 48 patients. 32 patients had a good response, had some response that was objective and meaningful. That includes a complete response and partial response. And then 44% of patients, that is 21 out of the 48 patients, had a complete response. What we noted that in the responders, the median duration of response was 9 months. And here I highlight in red the median time to response. And this is very important in the relapsed and refractory primary CNS lymphoma patients because we know that the disease, when it starts recurring or if it's not responding to high-dose methotrexate, people progress very rapidly. Time is short. And so we need therapies that work really quickly. And this is sort of a race, if you may, against trying to, start the treatment, but also shrink it so that we can get neurologic stability and improvement. And so what we noted here is that the median time to response was 1 month. As within a month, patients were having a very good response. The median progression-free survival rate was 6 months on this study. But if you look at the swimmer's plot, all of these lines in red, there are several patients that did well way beyond the 6 months, as you can see, and had prolonged responses. And by the way, this data cutoff was in November of 2024. And of course, there's more to come with that regard. And then another important part in brain tumor patients, and particularly primary CNS lymphoma patients, is corticosteroid dosing. We know that this drug, dexamethasone, works really well in brain tumor patients. It helps with edema and helping with symptoms, but especially in CNS lymphomas, it also helps in shrinking tumors. But then these drugs have long-term side effects and can interact with treatments and cause side effects in terms of infections as well. And so we wanted to see how many patients could really discontinue the steroids. And here in this study, we noted that 69% of patients that were on steroids at baseline were able to completely discontinue the steroids, and 81% of patients had a sustained reduction. Really good efficacy all in all. At the time that the PROSPECT study was introduced for relapsed and refractory primary CNS lymphoma, seeing that there was efficacy, there was simultaneously another study that recently completed accrual. And here, this was thought that if tirabrutinib or BTK inhibitors work well as single agents in the relapse and refractory state, why not bring them in the upfront setting and see how well they can be tolerated with the combination of high-dose methotrexate-based treatments? And also, can we enhance the efficacy and prevent the refractoriness? And so more data needs to come from that study, and I won't talk much about this right now, except for the fact that we've completed accrual, and such studies are very important as we move forward with treating this disease. So where did we go? Well, after the encouraging results of the PROSPECT study, there is now a randomized phase 3 trial. And of course, when we do clinical trials, we first initiate phase 2 trials, which are very important in understanding how efficacious the drugs are and the safety profile of the drugs. Are people having too many side effects? Is it well worth it? But then once we see efficacy, we really want to compare it to what is considered standard of care in that regard to really confirm these results. And that requires randomized studies. And that brings me to the IGNITE study, which has just recently opened. So this is a first phase 3 trial in relapse refractory primary CNS lymphoma. And, this is a big achievement for our patients because this is the first time this is ever happening, that we have achieved such profound results that we're able to actually conduct a phase 3 confirmatory trial. So this is the trial design. It will include, it is including all patients with relapse refractory primary CNS lymphoma. The randomization is 2:1, which means that out of 3 patients, 2 patients will receive tirabrutinib, and 1 of the 3 patients will receive the standard of care treatment. And here our comparator is rituximab and temozolomide, which will be given for 6 cycles. Tirabrutinib will be given in the standard dosing, which is the 480 milligrams oral daily, and will be continued until, of course, the disease progresses or patients have unacceptable side effects or are unable to participate for other reasons. So what we're hoping to assess as a result of this study is basically to see how do patients fare, not just in terms of responses, but how long does the response last? What is the time to progression? And we're going to measure progression-free survival in addition to overall response rate. And of course, importantly, overall survival amongst many other endpoints. Who's eligible? Well, as I mentioned, relapse refractory B-cell primary CNS lymphoma that have been confirmed, people over 18 years of age that have received at least one line of prior therapy with high-dose methotrexate. Again, measurable disease. This is important for us to show that there is indeed shrinkage and some response when tumors are coming back. Patients that have adequate organ function. So who are excluded? And the major exclusion factors are if there's isolated eye disease or isolated spine disease. Now, it doesn't mean that those that have brain disease that have also concurrent eye disease are excluded. So concurrent eye with the brain are going to be included. Concurrent spinal cord with the brain are going to be included. But if they had isolated eye or spinal cord disease, these wouldn't be included. And the reason for that is because it becomes hard to measure the response in these trials. Systemic lymphoma, of course, becomes a different disease, and that's the reason why these are excluded. Again, those that have other active malignancies that require other chemotherapy. And importantly, if people have received prior BTK inhibitors of any other kind, those would be excluded. That's about tirabrutinib. I'll move to another BTK inhibitor, zanubrutinib, and these results were discussed by my colleague Chris Fox from the UK, and this was a UK cooperative group study, a similar study that is called PRISM. And again, in this case, with zanubrutinib, the response rate was 55%. And their median progression-free survival rate was 6.9 months. So similar results. Gonna just mention very briefly targeting IRAK because this is also going to be discussed as a part of this webinar by Dr. Hamdi. So I'm not gonna take so much of his time, but just sort of talk about how there is synergistic activity between IRAK4 and BTK and value in combining emavusertib, which is an IRAK4 inhibitor, with BTK inhibitors like ibrutinib. Moving next to CAR T-cell therapies. And these are some of the FDA-approved CAR T-cell therapies in diffuse large B-cell lymphoma, systemic diffuse large B-cell lymphoma. And what I'd like to highlight is that none of these trials included patients with a history of or active CNS involvement at the time of their initial studies. And part of the reason why these patients were excluded was because there was a concern that people would have what is called eye cancer or neurotoxicity. There were symptoms that occurred in patients that didn't even have brain tumors. So the concern was that if patients with brain tumors were included in these trials, would the toxicity in the nervous system be even higher? And so all our CNS lymphoma patients were excluded from these trials. Primary CNS lymphoma, in fact, was an absolute exception in the United States until February 6th of 2026, which changed a lot. And I can talk about the story that led to this change. So this was a pilot study that we conducted at Dana-Farber of axicabtagene ciloleucel in relapse refractory primary and secondary CNS lymphomas. And here, what we wanted to ask was really, can we give axi-cell or CAR T-cells safely in patients that have brain tumors? And so we had a cohort of 18 patients, and the treatment for CAR T-cells would be the same. And I'll go quickly over just how we think about treating people with CAR T-cells. So we'd screen patients, they would be enrolled, And they have to go through a process called leukapheresis, where we have to collect cells. And then these are then sent to the lab to be manufactured into the CAR T cells. And then before the CAR T cells are actually given, patients have to go through a process called conditioning chemotherapy so that their body is primed to receiving the CAR T cells once they're given. And then people get CAR T cells, and then they're observed for at least 7 days in the hospital. Well, why in the hospital, you'll ask? And that is because we expect that patients will develop what are symptoms immediately upon receiving the CAR T cells. And some of these symptoms are divided into two. One of them all cytokine release syndromes, which is a constellation of symptoms. And then there's another set of symptoms that can develop, which is ICANS or neurotoxicity. And these all are seen to develop within the first week or two, and patients are monitored in the hospital for that. These resolve by about 10 to 14 days. And so the question was, if these occur in systemic lymphoma patients when there's no brain tumor, obviously the CAR T cells are actually trafficking into the nervous system. So perhaps they'll have a response on the system. So if they're causing toxicity without even brain tumors being there, perhaps we can see shrinkage and not just additional symptoms, but we wanted to monitor to see that additional symptoms did not become too problematic. What we found in terms of safety with this study was that 89% of patients developed any grade cytokine release syndrome, but that was only grade 1 or 2. We did not see any grade 3 or higher. And with regard to ICANS, 44% of patients developed ICANS. Importantly, this was very similar to what was seen in the systemic lymphoma trial. So it was no different in terms of side effect profile. So brain tumor patients did not have higher toxicity just by having the brain tumors. And in fact, these were similar results. What about efficacy then? What about the responses? Well, we found that 89% of our patients had a response in the nervous system, out of which 67% or 12 out of 18 patients had a complete response. One of the things that I want to mention with the cellular therapies is that the time to response, though, is delayed. And unlike what we see with targeted therapies such as BTK inhibitors, which work very quickly, CAR T cells take time before we start seeing shrinkage, and the median time to best response was 3 months. However, we did see in our study that the median duration of response was a little over a year, and so was the median progression-free survival. Based on our study, the FDA approved a label update for Yescarta for relapsed refractory primary CNS lymphoma. And what I want to highlight is that this is not the same thing as getting an approval. This is a label update, but it is one step forward in making progress for our patients. This is another novel CAR T cell, which is targeting CD20 and 19, which we also studied in the context of a larger study. It was a company sponsored. This is DALI-2. Again, our responses similar, seen at 85%. And then again, safety was also similar to the systemic lymphoma cohort. So as you can see, there are increasing a number of companies that are interested in and comfortable with doing trials that include CNS lymphomas now. So where are we with challenges? Well, in the relapse and refractory setting, we found that when we introduce these therapies, even though they work really well, the responses are not durable. In some therapies, like CAR T cells, there can be a delayed response, so we have to worry about that. We have to worry about the role of corticosteroids because we know that they can increase the risk of infections. And then there's a concern for neurotoxicity. And of course, then as a result, it makes it harder for us to interpret MRI response. We need to move novel therapies in the frontline setting. And so If we move the novel therapies in the frontline setting, we're basically going to be at a point where we'll improve response rates and reduce the refractoriness that we were talking about. And some therapies that we're looking at are BTK inhibitors, such as ibrutinib and tirabrutinib, which I talked about before. Drugs like lenalidomide are also being considered, and checkpoint inhibitors like nivolumab and pembrolizumab. And then what about consolidation? Well, maintenance therapy is something that we have to see in primary CNS lymphoma, and whether it's BTK inhibitors, IMiDs, checkpoint inhibitors, or CAR T-cell therapy, we'll have to see how patients fare. So which population can we actually study this in? Well, to start off with is, of course, transplant ineligible patients, but hopefully, be able to sort of go through this for all patients. So this is a study that we now have open, the Carolyn study, which is another CAR T-cell therapy, lisocabtagene maraleucel or liso-cel. And this is in newly diagnosed primary CNS lymphoma patients that liso-cel will be given after a high-dose methotrexate-based therapy, particularly in patients that cannot get consolidation with auto transplant. So key eligibility is basically transplant ineligibility and having methotrexate-sensitive disease that is a partial response or a complete response at the time of enrollment. So with that, I'll conclude speaking. Basically, I want to highlight that primary CNS lymphoma is very distinct from all systemic diffuse large B-cell lymphomas, and maybe just a subset of diffuse large B-cell lymphoma. It has unique targets. There is increase in the number of clinical trials that are utilizing novel agents in newly diagnosed and relapsed refractory primary CNS lymphoma, including phase 3 trials. Novel agents have now become an integral component of salvage therapy and are now increasingly being investigated in the frontline setting. I'd like to thank, of course, all of our team at Dana-Farber, but also other collaborators, particularly my colleague and one of my best friends, Christian Gromes, who will speak soon. And of course, all of our funding sources and Brain Cancer Initiative. And importantly, again, patients, families, and caregivers that always are a source of inspiration for doing all the work that I do. With that, I'll stop and take questions.
Thank you, Dr. Nayak. Wow, what a fantastic overview of PCNSL 1 and 2, the new developments in PCNSL history and looking forward. Things are advancing, thank goodness, in this disease for this patient population. It's very hopeful.
Indeed.
Excited to see that. So it is Q&A time. And I think I will start with a couple. There's some questions that came in ahead of time when people were registering for this webinar. I think I know the answer to this, but let's ask the question. So what is the current overall response rate for CAR T-cell therapy in PCNSL patients? And what is the typical median duration of that response?
I think we need more studies to have a broader answer on this. There are currently 2 CAR T-cell trials that have been completed, but both have been in single institutions. So one is the study that I just showed with Axicell that led to the label update. And as you saw in our study in 18 patients, we saw that the response rate was quite high, and the complete response rate was 67%. The durability of response was also over a year, which I have to say was very unexpected in this heavily pretreated group. There was another study with Tisa-cel, another CAR T-cell therapy that was conducted by my colleagues at the Mass Hospital. There, the CR rate or the complete response rate was about 50%. Which is not too far different from ours. And their duration of response, though, was close to 6 months. What we really need to do is have larger studies with multiple, institutions so that we can really have a good understanding of how people do. Because all of the other data that we have is really retrospective from secondary CNS lymphomas. And it's hard to really interpret these results because what was really the situation in which some of these patients received those therapies at that time. And, the best part of clinical trials is really that we try our best to streamline and homogenize the people that we study so that we can interpret the results in the best possible way. And that can only lead to an approval process more quickly so that it, can then be utilized and studied in the real world.
A question came in. So you recommend that everyone with PCNSL do a trial? Question mark. I had a transplant and it came back in a year, and I am finishing a full year of methotrexate and am in remission. Would you recommend wait and see or do something else at this point? I am 45 and fit.
Thank you for that question. So with regard to do I recommend everyone with PCNSL do a trial? Yes. However, with a caveat. So in the newly diagnosed primary CNS lymphoma setting, there are two challenges is neurologic deterioration can happen very rapidly. And so can you wait? Probably not. And trial enrollment takes time. So it really is very subjective, and it can be, it's not a same size fits all sort of approach. If possible, if feasible, consider a clinical trial. And if not, try to get a second opinion depending on where you're at in terms of which institution you're receiving the treatment at. Again, the standard of care is at this time high-dose methotrexate-based chemotherapy followed by an auto transplant in younger patients that are fit and able. And so, my vote is always to proceed with that if possible. And if there is a possibility of adding a trial, sure. But, standard of care should not be withheld in the time you wait for a trial. If this was not available, it would be different because time is brain. And the faster we treat patients, the better they recover. With regard to the second question, had a transplant, came back in a year, and finishing a full year of methotrexate. And so at this time, it seems like there is remission. And so from a trial perspective, the only possibility would be when the tumor would come back. And I think that in this case, because the tumor came back within such a short period of time, after the auto transplant, which is heavy duty chemotherapy, happy to see the response to methotrexate, but I would be concerned that there could be a possibility of recurrence again. And so there should be very, very close follow-up so that the imaging can be done maybe every couple of months so that there's a close watch and a plan to start something next before you become symptomatic and start having problems. So there's time to enroll on a trial. I actually wanted to ask Dr. Burmis for his thoughts as well.
Oh, well, thank you. No, I do agree with you. As always, we always agree. We actually sat together next to each other while we were fellows. So long journey together. We agree. Everyone who has a primary CNS lymphoma, because it's a rare disease, should be in a clinical trial. Now, should you travel around the United States or in a different country for a trial? No, because the standard of care is actually very effective, as you heard. There are patients that recur, but there are also patients that are cured. So The problem is we have no biomarker that can, at the moment, at least predict who is at risk of an early recurrence. Maybe when we have that, we can, stratify our treatment better. And so, but when you're in remission, usually, trials are not an option. We need some tumor that develops, because then we can apply that. And the question is just, how to closely monitor you and to react very quickly if there's a problem. And I'm very happy to hear that after that scare of having an early recurrence, that we're back to a remission. That's always good news.
Very good news. Awesome. Shreya, you had a question that came in.
Yes. Hi, Dr. Nayak. Thank you for a wonderful presentation. So last year, EBCI conducted a PCNSL patient and care partner survey, and that gave us a lot of really valuable insight into the patient experience. But one thing that stood out was that 60% of the patients felt like the information they received was not enough. And many of them turned to web searches and social media to fill in the gaps. From your perspective, Dr. Nayak, what resources or approaches would you recommend to the patients and care partners who are trying to find reliable, up-to-date information about PCNSL?
Thank you, Shreya, for this question. I think this actually remains an issue in all brain tumors. And we have conducted similar surveys for glioblastomas too. And not to talk about that here, given the topic of choice, but, I believe this is primarily driven from the fact that these are rare diseases compared to other cancers. And so the awareness from the medical community, actually within the medical community, also needs to be increased. And, in terms of the medical oncologists in the communities that are actually caring for many of the patients, we are doing quite a bit of, educational work with regard to that. And there is a lot of focus now on neuro-oncology to bring about significant awareness, and also to talk about, what is the standard of care. One of the things that we didn't talk about, for instance, is I highlighted, performance status, but it's very important to know that, if someone with a systemic lymphoma had a poor performance status, the treatment would be tailored to that performance status. Whereas in primary CNS lymphoma, newly diagnosed, we would give high-dose methotrexate regardless of the performance status, because we know the performance status is actually impaired because of the disease. And when the disease is reversed, it improves. And this is kind of awareness that needs to be sort of there in the community medical oncologists when they decide choosing to treat or not to treat. With regard to, how can patients and caregivers sort of learn more, I actually really appreciate forums such as yours and others that provide patients the resources. The LLS, or the Leukemia and Lymphoma Society, and the LRF, or the Lymphoma Research Foundation, is also very active in providing information to patients and caregivers about that. And, within our group too, we have we're very open to receiving emails about this, and we're trying to actually formalize a process as we move forward to allow for, patients from other places to get care and also to have all the information.
Excellent. Thank you, Dr. Nayak. While you respond to the next question, Elise, will you please put up Dr. Nayak's slide? It has her email address on it.
I do want to highlight that when I do get emails from patients, I encourage highly to ask your doctor to reach out to me, and I'm very available to talk to them and discuss protocols and treatments with the doctor so that I can get a better understanding of what the disease and the clinical status is overall to provide the right treatment without having seen you, of course.
If I may also chime in for a second, there is also the opportunity nowadays with telemedicine to get second opinions outside your state. Some of us have licenses not only where we practice, but also in other states. So access to physicians is easier. And so this methotrexate is not an easy drug. Not everyone wants to give it. So there's a little bit of a hesitance sometimes to treat patients with methotrexate, especially when they develop some problems with their kidney function. And so second opinions are always something I encourage my family members, my patients. It's not something that speaks against the doctor that you're working with. It's just something that helps. And sometimes I'm very surprised about the ideas my colleagues have, and all for the individual patient, and whatever we can do all together to make that happen and to make the care better, then we should do that. And second opinion helps with that.
I agree with you, and thanks so much for bringing this up, Christian. The possibility of online second opinions, as well as, so we offer that as well. And as Dr. Gromis mentioned, this is a very important point. And, there are times when there are certain complicated situations where I feel it's always best to have multiple, opinions. And occasionally, if my own patients are not able to travel and see Dr. Gromis or vice versa, we just pick up the phone and chat or, speak with others. And so, it's, while it's a small field, I think we're all very connected with each other. And at the end of the day, it's all really about the patient. And they are the most important people here. And all we're doing is for them. Everything else is secondary. Is there any treatment, I'm taking the next question, or other action that we should be taking after complete response to standard of care or transplant? So I personally, at this time, do not necessarily recommend anything after a transplant if there is a complete response, unless it's a part of a clinical trial, because that will help us learn. I personally don't recommend doing anything outside of a clinical trial in that regard if there's a complete response. Now, if there's no transplant or no consolidation, there's clear evidence that even with a complete response, if there's no consolidation, the risk of recurrence is high. So increasingly here, we're trying to increase our number of trials that we have for other consolidative methods, like one that I showed earlier, like lysocell and some others. When we participated in the tirabrutinib plus chemotherapy study that allows for tirabrutinib maintenance, and there are other such trials that allow for maintenance therapy. I think it's important to see if such trials are available. Dr. Gromis, do you have comments?
Yeah, no, I agree. That's the beauty of this disease. If you have complete response and a remission after consolidation, that should be it. So I think that outside of a trial, having additional treatments might just add toxicity rather than benefit. But yeah, there are multiple trials, CAR T-cell trials. We have a randomized trials for observation versus obinutuzumab versus the CD20 antibody. That is a multi-center natural trial. So these are trials that are available, and I think it's important to have them because we can answer questions and can also maybe challenge the idea is, do we need maintenance or not? And I think that within like the next 5 years, I think we have a better understanding if we need maintenance or if new consolidation regimens like CAR T cells or even BTK inhibitors like the tirabutnib study allows tirabutnib maintenance are actually beneficial. It's safe. We know that. There's a study that was done in Israel where elderly patients, now what is elderly, 65 or 70 and older, were treated with RMVP chemotherapy, so methotrexate, and then were continued on the maintenance with ibrutinib. That is clearly possible. Patients were safe, but was there an additional effect? We don't know because it was just a single arm study.
I have one question, Dr. Nayak. So we wanted to make sure that everyone knew that Dana-Farber allows for virtual and Zoom consultations for patients outside of the U.S., and there are several online second opinion forums where patients can ask for specific experts. Can you talk about that a little bit?
Right. I was actually looking to find the link that I could attach if possible.
Okay.
If I can send it to you.
Absolutely. And we can actually include it as part of this webinar. I think that would be really, really helpful for our patient population.
Yeah. So there's one forum that we definitely use called Access Hope that allows patients to send for remote opinions. There was also another one called Grand Rounds that also allows for second opinions. And those are written assessments. So, the notes are collected by the company and sort of put together and then sent to the experts. You could specifically ask for which expert you want based on their availability and willingness, of course. And then with regard to the international consults at Dana-Farber, it does require the physician to also be present. What I wanted to highlight is that, while, many of us are open to receiving emails, even from physicians, and do, give how you say, an unofficial opinion, what happens is that we're not really seeing the whole breadth of what is really going on. And that's important to note. So, at the end of the day, we trust. The reason why we like to talk to the local oncologists is because we trust their judgment and what the overall situation is like, so that we can sort of guide accordingly and then cater to, as opposed to, as I said earlier, it's hard to make it the same size fits all, approach.
I also think it's important. I realize you're making a second opinion based on the information that you have, which is not the full picture. But I also do think that interaction with the patient and the expert, it is a first step. It is starting to create, basically, it's that one-on-one engagement, which we have to have in order to really seek and be able to get full second and third and fourth opinions by being seen within the physician's office. So thank you.
Yeah.
Thank you. Thank you so much for bringing those two resources up. Excellent. Thank you so much, Dr. Nayak and Dr. Gomez, who we will hear a little bit later from. Dr. Gomez, thank you, Dr. Nayak. So informative. I feel like we should have given you more time, but I do need to move on. You have been fantastic. I also want to remind everyone that our patient navigator, Shreya Prakash, can also help put you in touch for second opinions as well, second, third, fourth opinions, as well as put you in touch with Dr. Nayak, Dr. Gromes, Dr. Lily, Dr. Hamdi, who you will hear from soon.